Good morning. I'm Marcia Horn with ICANN and the Exon 20 group. We welcome everybody today and thank you so much for joining, especially during such a difficult and harrowing time as the global COVID-19 crisis. We at ICANN, the International Cancer Advocacy Network, are proud to support and sponsor this TRK Fusion Cancer webinar today. ICANN is a 501c3 charity. We're based in Phoenix, Arizona, and we specialize in rare cancer patient advocacy and research advocacy. We're also involved in public policy, and we're working hard to reduce health disparities. While we've been in advocacy for 24 years now, we're deeply involved in rare cancers and particularly rare lung cancers. We've spearheaded the Exon 20 group, which is a working group and multi-stakeholder international coalition seeking to defeat two very rare mutations, EGFR exon 20 insertions and HER2 exon 20 insertions, each of which are present in 25 separate cancers. Because of the Exon 20 group, we at ICANN are daily connected to molecular profiling reports, clinical trials matching, and we work closely with patients, caregivers, and clinicians. So we're really pleased today to support the first patient and care partner webinar for people affected by TRK fusion cancer. We know this is a very rare cancer type, which can make the patient journey often isolating. But you're here among friends, new and old, and today is an opportunity to bring together patient and care partner voices and answer some of your critical questions. So today we're going to be talking about the TRK fusion cancer journey, testing and beyond. We're going to have that followed by Q&A. We're going to have the TRK fusion cancer patient experience and touch upon some of the challenges in accessing diagnosis and support. And then we're going to have a community poll on ways to improve education and awareness for TRK fusion cancer. So the webinar recording today is going to be made available online to download on the ICANN website. Delighted to introduce to you our excellent speakers. Sandra Montez, Research Nurse Supervisor at the University of Texas MD Anderson Cancer Center, who has been helping to run clinical trials for investigational cancer therapeutics at MD Anderson since 2016. Sandra supervises 12 nurses and coordinators across 27 active clinical trials. Prior to joining MD Anderson, Sandra worked at hospitals in Australia and in the United Kingdom. Sandra is a powerful champion of the patient voice, and it's been wonderful working with her over the past year. Our next speaker, Susan Spinoza, founded the NTRK Facebook support group after being diagnosed herself with TRK fusion thyroid cancer. It's been wonderful to work with Susan, and she's been greatly contributing to today's webinar content. So thank you, Susan. Miranda Bowman will also join us, and Miranda's son Hunter was diagnosed with thyroid cancer at the age of 9 in 2014, and he was later to test positive for the NTRK gene fusion and entered a clinical study at MD Anderson. Miranda is going to describe for us her experiences. Keith Taggart will also be joining us today. Keith's a very established member of the NTRK community and was recently nominated for the prestigious AACR, the American Association of Cancer Research Scientists and Survivor Program, which is a big, big honor. So thank you, Keith, for joining us. Tim Turnham from Boz Advisors will help us today and facilitate today's discussion and the running of the webinar. Tim used to lead the Melanoma Research Foundation and has tremendous experience working on global oncology issues. Great to have you, Tim, and it's a delight always to work with you on cancer issues across the tumor space. So over to Susan Spinoza, founder of the NTRK Facebook support group. Susan?
Yes, hi, thanks, Marcia. Hi, I'm Susan. I'm a thyroid cancer survivor. I was diagnosed in 2004, and finally 2 years ago, I was diagnosed with NTRK positive thyroid cancer, and I've been on targeted therapy since then. I'm very excited for everyone to be here today. I know it's a very stressful time with the virus, so I'm extra thankful for your energy and time today. Some of you may already know me from the NTRK support group on Facebook for patients and caregivers. I set that up after years of asking questions and trying to find the right diagnosis and support. So if you're not already following us on Facebook, you can go on and search under NTRK support group and ask to join. You can also follow us on Twitter at #TrackFusionCancer or #TrackTogether. So in today's webinar, we hope to hear more about track fusion cancer and testing, understand the challenges we face when assessing diagnosis and support, and to consider how education, awareness, and support can be improved. So we hope this is the first of many webinars to come for people like you and me. We will be mailing out or emailing out a survey after this meeting, so please respond and give us your thoughts and feedbacks for future topics. Again, this is our first webinar, so it's going to be a learning process for all of us. And again, if you'd like to stay in touch, please do so through Facebook and Twitter. And now I'll hand it back over to Tim.
Thank you, Susan and Marcia, both for setting up things quite well. We'll have a presentation from Sandra, and then we'll be able to hear from some patients about their personal story. And after each of these, and then at the very end of the time today, we'll have an opportunity for questions and answers. Because we have a large group of people who are participating here, we have participants who are muted, so you won't be able to ask a question verbally. But to the right of your screen, there's a little panel that says questions, and you can submit those questions. We have people who will be monitoring your submissions. You can do that anytime during the presentation. And we'll hopefully have a chance to get to all the questions, but at least we'll get to some of those questions. And again, we'll have some polling at the end. All right, so we're going to move on to the meat of the presentation. Sandra, I'll turn it over to you. Thank you.
Thank you so much. I know some of you also on this call, presumably you've been treated with us here at MD Anderson. I won't go through any introduction because that was already done so nicely. So I'm going to go through an overview of what I'm going to talk about today. So we're going to talk about what do we mean by a track fusion cancer. How and why and when do we test patients that we think may have a track fusion? I'm going to go through a little bit more about what we have learned over the last few years. I've been involved with track fusions since the early phase 1 trials for about 5 years now. And I'm also going to go through some interesting cases with you from patients that we've seen over the years. So, you know, what is this precision medicine that we talk about? What's unique about track fusion cancers? So what we're doing here is we're going to look at a different person, and I'll go into this in a couple of slides, whether it be their whole genetic makeup or just the genomic makeup of the tumor. And we're trying to find faults in genes that may be associated with either increased risk of cancer or potentially what's causing the driving the driving force of that person's cancer. So what we're finding as genetic testing becomes more widely used in cancer diagnosis, we're seeing an emergence of these targeted therapies, and the NTRK gene fusion is a really good example of this. So what was previously considered either too difficult is quickly now becoming standard of care as this genomic testing is becoming widely available in the cancer community. We're seeing more and more, as you've heard before, like the exon 20s, more and more alterations being identified as these drivers of cancer. And we're seeing an increasing number of drugs be approved, even in small patient populations, which is great news. This one is exactly right. So when a doctor or you read on the internet, what are the different forms of genetic testing available? So we talk about genomic testing, which is where we're looking for alterations or mutations specific to the patient's cancer. And when we talk about genetic testing, we're looking at a whole person's genome. So to get a little bit more granular here, the easiest way for me to remember this and how I explain this to my patients is genomic testing refers to something called somatic mutations. So they're mutations that exist specifically in your cancer only. And so if I were to take a sample of your skin, your hair, your saliva, and your tumor, that mutation would exist only in the tumor, but can also be a driver for its growth. And when we talk about genetic testing, we're looking at the patient's whole genome. So if I were to take a sample of your saliva, your skin, your hair, and your tumor, they would all share the same mutation. So an example of that most people have heard of would be the BRCA gene mutation, where it can be what we call germline. So it exists in your DNA, it's an inherited mutation, whereas genomic testing doesn't typically talk about inherited mutations and exists only in that person's tumor. So what exactly are gene fusions? So they're the recipe for proteins, some of which are used for presenting cancer and some of which are the cause of cancer growth. So these gene fusions, this is a lovely graphic here where you can see two separate genes. One is a pizza, one is a burger, and one is blue and one is green. And for some reason unknown to us, part of the pizza and part of the burger snap off and create an entirely new gene in somebody's cancer. So you can see there that the two chromosomes, the top part and the bottom part, are now blue and green together, but the colors of the actual burger and the pizza aren't green and blue anymore. They're kind of teal and pink because you get an entirely new gene that has formed, and that typically only forms in that cancer. Something we see here is this is a unique event where these two separate genes now become like addicted to growth, and that's what causes TRK fusion cancers to grow and to spread. Can we go next slide? Yeah, perfect. So what exactly is a TRK fusion cancer? So, you know, the gene fuses, and this leads to this activation of abnormal proteins, which can fuel this cancer growth. So if you look at the top graphic, that's a normal cell cycle. So you've got this normal NTRK gene, the protein is normal, it binds, regulates cell growth, and it moves on. The cell grows, dies, moves on, and there's no abnormal growth. In the cancerous pathway, which you can see below, you have that same blue-green NTRK gene fusion, and it's got these abnormal proteins, so it affects the way that the cell replicates. So you don't need any molecules to activate this pathway, which you did before, and so it just grows and leads to this uncontrolled cell division. So an NTRK inhibitor essentially turns off this rapid cell division. So the question then becomes, how and when do we test these tumors? So there's a couple of different methods we can use. The method of choice that most people have heard of is this something called next generation sequencing. So the advantages of that is it's a high throughput method where we sequence DNA or RNA, and we can sequence that from a previously taken or a fresh tumor sample. There's something called FISH testing, where it's essentially what we call a fluorescent probe that has really high sensitivity and specificity, However, the problem with this testing is you have to know what you're looking for before. So with the next generation sequencing, you can test for, 100, 200, 500 genes at once. The disadvantage is it has the longest turnaround time and it's the most expensive of the tests. The FISH test, like I said, you have to know that you're looking for NTRK. You can't just do this broad 400 or 500 genes at once. And it cannot show that the fusion necessarily has this protein loss. It can just show you that the mutation is there. And then you've got this immunohistochemistry. So the way I like to think of this is, and the way I explain it to my patients is, it tells you how brown your tumor is. So what it does is it is a stain that you add to tumor slides, and if the tumor goes brown in nearly 100%, it shows you that you have this protein available. The advantage is it's extremely quick, it's extremely cheap, but it's not very specific. So they're the three kind of tests that we use. There are more tests available, but these are the three most common we use. So when do we test for NTRK gene fusions? There is no standard guidance here. It varies to institutions. In an ideal world, if time, money, availability of tumor tissue wasn't an issue, you might want to test all patients that have locally advanced or metastatic disease. The populations you would certainly want to target would be cancer types where NTRK fusions are more frequent. So we say that you can find an NTRK fusion across 1% of all cancer types, but if you start breaking down those tumor types, such as a thyroid cancer with a no known BRAF mutation, you're looking at much more like 20 or 30% of patients. So they would be the patients that you would be definitely targeting. So you can see that across the tumor types on this graphic, there are tumor types that 100%, there aren't really any circumstances where you wouldn't test for an NTRK fusion. So salivary gland, previously known as MASC, but secretory salivary gland cancers, secretory breast cancers, infantile fibrosarcomas, and then congenital nephromas. This is what you might hear as being called pathognomonic. So the almost 100% of those cancer patients have an NTRK fusion. And then in the cancer types that you see that are black, we see an enhanced population, and it varies amongst those cancer types what percentage of positive NTRK fusion cases we will see. So some of the key takeaways that we have from here are that precision medicine works. We can see from NTRK inhibitors here that we see a really nice, long, robust response rate in patients that harbor an NTRK fusion, but the population of people that harbor that fusion tends to be small. So one thing we talk about at MD Anderson is this fusion is rare in common cancers such as colon, lung, breast, but it seems to be common in a subset of very, very rare cancers such as salivary gland cancers. And although the population is small, there's still patients out there that have clearly benefited, and the exploration needs to be made into NTRK fusion therapies. We see that resistance to these therapies can still ensue. So the cancer tends to get, I showed you that pathway. The cancer can get smart and find a way around the NTRK inhibitor, and then we can, eventually see cancer growth again. So what do we do about that? And two of the answers I'm going to discuss are next generation inhibitors and rational combinations of therapy. So some of the research we've done has been into this preclinical modeling. So what happens before we give it to humans? What happens in animals? And we've seen from other cancer types and other mutations such as ALK and ROS1 that also have this problem of resistance to ALK inhibitors and ROS1 inhibitors. We've also seen clinical case reports where patients can receive a second generation inhibitor and respond to that therapy, and there's ongoing clinical trials into that as well. So what are some of the key findings of these mutations that gain resistance to an NTRK inhibitor? So we find that in the NTRK story, the tumor becomes addicted, or stays addicted to the same gene alteration. So they're still addicted to NTRK, and it's something called a solvent front mutation that stops the drug binding to in the same way that it was to the NTRK gene. And so a second generation inhibitor can overcome that resistance. And what other developments are around? So are there rational combinations we can try? Anybody that Googles targeted therapy will find that the most common thing that we're seeing now is combinations of therapies. So can you put a TRK inhibitor with immune therapy? Can you put a TRK inhibitor with something that we know will prevent developing one of these resistance mutations? We talk about NTRK fusions, but can TRK inhibitors be beneficial to patients with mutations or amplifications in NTRK genes? And how are these different? So a TRK fusion, like I described before, is two separate genes have broken off and fused together to create a new gene. And amplification is where the gene rapidly divides. There's too many copies of the gene, so it's not a fusion. There's just NTRK there in the original form, but there are like a prolific amount of copies of it. And mutations, again, are where there's one gene, but somewhere in that coding of the gene, there has been an error. The data for mutations is not very strong. We personally put on lots of patients with gene mutations and we didn't see any responders, but I know that there's going to be clinical trials potentially opening in this amplification space. There are approved drugs on the market to treat NTRK fusion cancers. There are actually, I think, 2 FDA-approved drugs currently on the market, and then there will be, I'm sure, more in the future. And these next generation inhibitors are also in clinical trials, phase 1, phase 2 currently, for patients that have previously had and their cancer has gotten worse on one of these first generation inhibitors. So I'm going to go into some of these interesting cases. So when we first started working with NTRK fusion cancers, what we initially saw was mutation reports that just had one genetic mutation on it, not lots of mutations, not hypermutated patients. So what we initially thought was this could be the only oncogenic driver for the cancer, the only thing that could be driving this cancer's growth. And this is an interesting case of a patient with colon cancer who has had, this kind of 400 or 500 gene paneling done. And you can see that there are multiple mutations there, including an NTRK fusion cancer, as well as something we find in a reasonable amount of colon cancer patients, something called MSI high or MS unstable cancer. This patient ended up by going onto an NTRK inhibitor and responded for more than 2 years on therapy. The reason this is interesting is because MSI high cancer patients tend to be young and no other risk factors of colon cancer. This patient actually was somebody you wouldn't expect to find MSI high colon cancer, and the patient was in their late 60s, early 70s. So again, a subclass of patients that you might not expect to find these mutations. And the more we know about genetic mutations in NTRK, the more we're going to find these pockets of patients that we might identify an NTRK fusion on. The next interesting case here is a thyroid carcinoma on a 25-year-old patient. We initially did an NTRK test many years ago, and we didn't identify an NTRK gene fusion on this patient. The patient then went on to receive radioactive iodine quite a few times, which is a normal standard of care therapy for thyroid cancer. And then the patient unfortunately had progression of disease. And it's not something that you would normally do, but being such a unique cancer driver with NTRK, we retested this patient for the NTRK gene fusion. And this patient ended up by having what we call an atypical, so a less common type of gene, NTRK gene fusion, which was actually acquired from receiving the radioactive iodine. So this is a unique example that we think now is just specifically to thyroid cancer, but again, an interesting case of when you might have an initial negative result become a positive result subsequently many years down the line. And then the third interesting case here is just what I was talking about earlier about this potential for resistance. So this was actually my first patient that I ever treated on an NTRK inhibitor. So this patient had what we call a triple negative GIST, so a sarcoma in the gastrointestinal tract that was negative of all other known mutations that this type of cancer normally harbors. And the patient had an NTRK fusion, as you can see on the graphic on the left there, initially identified. The patient responded for nearly 3 years on an NTRK inhibitor, and eventually the cancer started to get worse. And you can see from the graphic on the right, which is the second genomic test, where the patient has this resistance mechanism of known NTRK. So one of these solvent front mutations that I talked about that prevents that first drug from binding. And this patient actually re-responded to a second generation drug, again, for quite some time. So the patient maintained this NTRK fusion, but developed this solvent front mutation. So I think that is all the slides from me. And I think, David, you're going to go through some of the questions, or?
Sandra, it's Marcia. Hi, Will.
Oh, hi, Marcia. Sorry.
That was a fantastic presentation. Thank you so much, and great explanation on testing. When do you think is the best time to test for NTRK after somebody has been told, hey, you have lung cancer? And also, do you test on disease progression at each pivot point, or only at some pivot points, and why?
Yeah, so I mean, coming from somebody that works in a targeted therapy department and has been deeply involved in NTRK, I would say that the moment that somebody has been diagnosed with an incurable cancer, so something that can't be cured with, surgery and radiation therapy, is a good time to start looking at a broad panel of mutations, and NTRK fusion should be included in that. In terms of when should they be retested, sometimes that's not an option, so there's not tumor tissue available or a biopsy that can be done. So you can do what we call a liquid biopsy from blood. But normally what we see done in our department is when a patient has gone on a therapy that we think can change the type of genetic makeup of their cancer, we will do retesting. So in the NTRK story, if a patient has been on a first generation NTRK inhibitor and their cancer gets worse, they definitely should be tested again to see if they have this solvent front or any other type of resistance mutation. For the general cancer population, I think normally after certain types of targeted therapy, we will usually do a second genomic test to see if there have been any new mutations or fusions developed.
Great. And I know each of the patients on our webinar today are going to be wanting to ask their clinicians on testing post each regimen and making sure that they chase the cancer as it evolves.
Yeah,
Sandra,
I mean,
you go ahead.
No. I was just going to say, yeah, that's definitely a conversation to have with your local oncologist at the time, because they'll have a better idea of, when to put your eggs in which basket and when this makes most sense.
And Sandra, you have had personal and clinical and up close experience with so many different tumor types implicated by NTRK fusion cancer. Is there any tumor type that you have yet to see that you would love to see to add to this impressive collection? And which types are elusive? You've mentioned the commonly diagnosed anticipate seeing NTRK in, but there's just no patients who've walked in the clinic door yet.
Yeah, I think that this is still an evolving story. It's a rare cancer. And one of the things about these genomic reports is sometimes people think they have had comprehensive genomic testing, but NTRK, now that we've got FDA-approved NTRK inhibitors, NTRK is included on more and more reports. But if you had testing 3 years ago, then chances are NTRK probably wasn't included, or certainly not the whole NTRK gene was included in the testing that you had. And maybe you looked for mutations and amplifications, but not for fusions. So I've been following the NTRK data coming out, twice a year, 3 times a year. And actually, surprisingly, something that we wouldn't have expected, we're seeing more and more breast cancer patients diagnosed with NTRK gene fusions. We've also seen, surprisingly again, several central nervous system type tumors, so glioblastomas that we weren't expecting. But I will say normally they're fit within a subset of patients within that cancer type. So if you're going to talk about lung cancer patients, for example, we have seen NTRK fusions in lung cancer patients where the patients are atypical for having lung cancer. So they are non-smokers, they are young, and they do not have mutations in EGFR, ALK, and ROS1. So a lot of oncologists that I've spoken to, when we see something that we're not expecting, if they're not already broadly doing NTRK fusion testing on all of their patients, these are the patients that they're targeting for that testing.
Sandra,
Excellent.
I want to follow up on what you just said. Thank you for that. Because I've heard some doctors talk about kind of enriching the pool because, as you say, the full panel of testing can be expensive and it can take time. So is this part of what you mean by having some way of anticipating which kinds of patients are more likely to have these NTRK gene fusions, so that you can have a richer pool of people for doing testing?
That's exactly right. So something like MSI, in the colon cancer example I gave, MSI high colon cancer is not commonly found in a patient in their 60s and 70s. So if you find a patient in their 60s and 70s that all of a sudden has an MSI high cancer tumor, that would be a patient at MD Anderson that we would automatically test for NTRK fusion, because we think that that's the enriched population. If we see a patient with thyroid cancer that doesn't have a BRAF or an NRAS mutation, that would be a patient that we would definitely test for NTRK fusion. Some of the other mutations are easier to find. They're a bit cheaper to find, and they happen in 40%. So in thyroid cancer patients, a large percentage have a BRAF mutation, and you can do that very quickly, very cheaply. So what you would typically do is look for a BRAF mutation first, and if that's negative, then take the next step. Because I actually personally have never seen a patient with an NTRK and a BRAF mutation. So that's exactly what I mean by enriching that patient population.
And could you just, I'm going to push this just a little bit further and talk about
No, go for it.
testing in pediatric cancers, right?
Mm-hmm.
Because, I mean, we know that some types of pediatric cancer do have tract fusions, but
Mm-hmm.
it's rare for children to have cancer. And of course, when a childhood cancer is diagnosed, it's just traumatic for the whole family. But so how do you see this playing into that pediatric cancer space?
Yeah, I mean, again, a little bit biased working in a targeted therapy department where this is, the reason that my department exists. But I would say pediatric cancers are extremely rare. Just by nature, they're almost atypical, right? I would be testing all pediatric cancers that, again, can't be cured by, say, surgery or standard chemotherapies. We're not expecting, an easy, for a bad use of word, cure. I would be testing all of those cancers for NTRK gene fusions.
So this is Marcia. I'm sorry, I didn't mean to interrupt you, but I have to ask one more question here. But I will ask the audience. Don't forget, you can submit questions through the little question box on the right-hand side. So I'm sure that we have some other questions out there. But one of the things, as you can see from the slide, Sandra, we were going to ask you about is what are the challenges with current testing and confirmation of results. But I'd like to twist this just a little bit, because you're saying, gee, we want to test all pediatric cancers for crack.
Mm-hmm.
You know that these tests are expensive. They're not always covered in all situations. So is that a challenge for, if you think about a parent with a child who has a childhood cancer and they're not going, maybe they're going to another institution. Are there barriers to getting the testing to determine if an NTRK gene fusion is a factor here?
Yeah, I think, if you have got, it's incredibly traumatic, I think, to have any kind of cancer diagnosis, but particularly a child with a cancer diagnosis. I mean, the testing is getting much cheaper. I will tell you, when I started testing our patients at MD Anderson, we didn't have an internal panel that could identify patients with NTRK fusion, so I was having to send everything out. And those tests were $7,500. And they would test, they were a good broadband 400-500 gene test. And those tests you can get a really good broad gene test done for about $1,000 now. And I suspect that's only going to get cheaper and faster. So when I first started doing testing, I would get results in 4 to 6 weeks. And now I've got many tests available to me where I can get a good turnaround time of, sometimes 5 to 10 business days, which is a far cry from what it was. And these things are only going to get cheaper and better. And as more drugs become available on the market, more of these tests are going to be covered by insurance. There are lots of foundations available that will help with this testing. So one of the largest commercially available tests out on the West Coast that you can get actually has like a criteria that you can fill in online, and you can be eligible for free testing. So I would encourage patients to explore those things. I personally, early on, was able to get probably about 50 or 70 patients tested for free, just using the online resources available for these testing platforms.
Thank you. And we're almost out of time for questions, but the last question was from somebody who is an audience. I remember somebody who's listening in. Mm-hmm. And then there's another one that is a great segue right after what you've just said. You've talked about West Coast group and things like that, but we have people from other countries, right? So mm-hmm. What about you? What about the availability of testing and how common it is to have access to that?
Yeah, I mean, I can't speak for, every country, but certainly, I mean, where I'm from, if anybody hasn't realized, I'm from a little south of Texas. I'm from Australia. It's much harder because there's very stringent availability, but the same thing. So I've helped people in Australia and England, Spain. There are usually companies around that will offer testing to patients free of charge, but yeah, it's limited, and you really have to know what you're asking to be ordered. So you really want to cover a gene, a nice broad amount of genes, so at least 150. If you can get 400 or 500, that's great. And the gold standard, if you have enough tissue and there's other factors like cost in play, would be to do a full RNA panel, so not just the DNA to do the RNA, because that's going to pick up all gene fusions as well. So the gold standard would be, a 2, 3, 4, 500 gene panel that covers RNA as well as DNA. But that's also going to be your slowest, most expensive test that requires the most amount of tissue.
All right, thank you for that. And I'm going to ask the last question, because I know that people have this question. I'm going to ask you to address it very briefly because we're a little bit past on time. And then Marcia, I'll turn it back over to you to introduce our next speaker. But Sandra, quickly, how has COVID-19 affected the diagnosis, management, and research about TRK fusion cancer?
Yeah, unfortunately, a lot of clinical trials have had to go on hold because of COVID. Lots of patients need to travel for these clinical trials. Fortunately, at our site, all of our TRK fusion trials have been able to remain open because of the benefit we see in patients. And again, fortunately, these aren't what we call these traditional immunosuppressive drugs. So like chemotherapies or certain other targeted therapies. So in the landscape of treating a cancer patient in the COVID-19 space, not a COVID positive patient, but COVID being around, TRK fusion therapy should be relatively safe in talking of cancer therapies as a type of therapy to give during the pandemic. We are seeing a few slower turnaround times from labs due to staff availability, but hopefully not too much has changed.
Okay, Marcia?
Thank you so much, Sandra. That was so illuminating, and we're delighted that you were with us today. And now we're going to be hearing from Miranda Bowman. Nothing is more important to the patient than the care partner or the parent. And at ICANN, for our pediatric patients, the parents are inspiring us every day. Miranda, we look forward to your presentation right now on TRK fusion cancer and your unique parent and patient experience. Over to Miranda.
Hi, thank you. So I'm going to tell you a real quick version of Hunter's story. This is Hunter in 2014 and now in 2020, a little bit of a difference. He was diagnosed at age 9 in 2014 with papillary thyroid cancer. We went to a children's hospital here in Michigan. He had surgery and 190 millicuries of RAI and not great results. The cancer kept growing and his doctors at the children's hospital were kind of scratching their heads. So we sought out an expert at the University of Michigan who usually treated older patients, but he agreed to take Hunter on. They did another surgery, and this time they did a bilateral neck dissection, another thyroid surgery, and then did dosimetry, gave him 360 millicuries of radioactive iodine, and nothing, and it wasn't good. Again, he still had tumor growth in his lungs, and things were not going the way they should be going. This was over the course of a year. So I started looking into the experts in pediatric thyroid cancer, and I found a doctor at MD Anderson. I spoke with our doctor at the University of Michigan and with the endocrinologist at the Children's Hospital, and they started emailing a doctor in Texas at MD Anderson and getting just consulting with him. I went to conferences in thyroid cancer. And finally, it was decided that Hunter needed to go to MD Anderson. And so we had some insurance hiccups, but we finally got him down there in 2016. So 2 years after he was diagnosed, we got him into MD Anderson. And that is where I got to meet Sandra. And Hunter was tested for NTRK fusion. And we were told by our doctor that down at MD Anderson that it would most likely not be positive. It's very rare in pediatric patients. And so we were told it probably was a BRAF, but Hunter hadn't been tested yet. So they tested him and of course, it came back positive. So Hunter began a clinical trial, and he's doing really well today, still on the trial, still doing phenomenally well. So it wasn't as easy as my 2-minute presentation or story would make it seem. We had a lot of hiccups along the way, getting him into MD Anderson, dealing with insurance, figuring out why his cancer wasn't responding the way it should be and the way most other people's did. So I want to share with you a couple things that I wish I would have known from the very beginning. And the most important thing I think that I wish I would have known is that it's okay to ask questions and seek out the experts on your own. Do not be afraid to advocate for yourself or your loved one. So when things were not going the way they should, I was really nervous at first to bring up anything outside of what my doctors were doing at the time. And what I found when I went to our doctor at U of M and I said, I went to this conference and there is this doctor at MD Anderson who is kind of on the forefront of pediatric thyroid cancer. He was very receptive, really excited, and knew the doctor already and said, this is a great idea. Let's consult with him and we will figure something out. And then our doctor actually at University of Michigan was the one who said, I think it's time for you to go exclusively down to Texas to MD Anderson. So the doctors want what's best for you. So don't be afraid to advocate for yourself. Also, as far as insurance goes, we had a lot of trouble getting down to MD Anderson. And then when the trial started, getting approved for the trial. What I found was, again, seeking out experts and then talking through things with your insurance company is actually something that you can do. You don't have to just take what they tell you. Sometimes you can seek out advice and then go back and say, hey, I looked over my explanation of benefits and I'm seeing that we are covered for clinical trials. And that's exactly what I did. And it worked. And so we were able to get him into the trial. The second thing I would say that I wish I had known was that other people are going through things that you are going through. And so to seek them out as well. So seek out the experts, but also seek out other people, other patients, and other caregivers. I learned of NTRK fusion initially from a thyroid cancer group. And then later I found Susan's group with other patients who were NTRK positive. And so those people can sometimes be the best line to where the experts are and to what the horizon for patients. And so seek the experts, but also seek other patients and caregivers so that you can learn from them. And I would think those would be my two most important pieces of advice as a parent of an NTRK positive child. I think that's
tremendous, Miranda. Thank you so much for that. You are an inspiration, and your advice on how to become a self-empowered advocate and never take no for an answer and seek out second opinions is so important, especially in the rare cancer space like TRK fusion cancer. Tim, do you have any additional audience questions?
This was really great. What I'd like to do is ask Susan and Keith if you could turn your webcams on and join us, and we'll just have a little bit of a discussion about the patient experience. But Miranda, thank you so much for that, and I think the points that you raised were spot on. And I'll throw in my camera here. And Susan, if you get a chance, we'd love to have you come on and make sure you're off of mute. But I was curious, Keith, maybe you could speak to this first, that in hearing Miranda's story and thinking about your experience and knowing of other patients, any other additional observations, any other points of recommendation for people?
Well, it's funny. This is the first time I've really heard Miranda's story like this. And I've got to say, my story was very similar. I'm from Oklahoma City, and I started my cancer journey in Oklahoma City. with radiation treatments and surgeries. The cancer kept growing, and we were not getting anywhere. And ultimately, I did go to MD Anderson also, and got involved with the clinical trial there. I didn't have any problems with insurance or any of that sort of stuff. It was all pretty smooth. I started the clinical trial in January of 2017. So I've been in the trial. I'm still in the trial. In fact, when this is over, I'm flying to Houston today for a trial visit. So I've been in the trial more than 3 years and haven't had any substantial cancer growth as long as I've been in the trial. So it's really phenomenal from what was something that was absolutely uncontrollable cancer growth to something that now is just doesn't seem to be bothersome at all. One thing, though, I would like to echo what Miranda says is that it's a real surprise to me. And after some of the drugs have started to get approved by the FDA, I've been involved with some efforts to help spread the word about NTRK fusion cancer and to see what we can do to help other people in my situation. And it's surprising to me how much resistance there is in the medical community to something that's so new like this. I think that when you're around the major cancer centers like MD Anderson or Sloan Kettering, they're very open to new things like this. But when you get out into some of the smaller areas of the country, the doctors just are not very cooperative at all. I'd say that they're probably resistant, not even hesitant, but resistant. So I would echo what Miranda says, is the patient really needs to they need to initiate I guess the investigation into NTRK or whatever. You know, it's just I'm really kind of surprised how with a new thing like this, the medical profession's just hesitant to adopt it.
I think, Keith, that's an interesting point. The slide that we have up on the screen now shows kind of a patient journey, and the first part around diagnosis is a real challenge sometimes in a situation like this, where getting that testing done and identifying that that's the issue. And if you don't want it to be a matter of luck, right? You don't want it to be that, oh, I happen to go to a doctor who's looking into this, versus somebody who happened to go to a different. It shouldn't be a matter of luck. It should be about science and what really makes sense. And sometimes you do have to advocate for yourself. Susan, your comment, your experience, or what would you...
Well, that was a good word that you used, was luck, and that's exactly what I had. I always heard about this genomic testing years before I had actually had it done, and I always denied it at my current hospital. And it was my luck that I went to up to Sloan Kettering to look at another clinical trial, actually to give me more radiation. And he said, you know, your cancer isn't acting the way it should. Let's do genomic profiling. So I was all on board to do that. And that's when it came back as NTRK positive. And that completely changed the course of my treatment. And if I would have had it done when I first started asking about it, I could have avoided more radiation. I had stereotactic beam radiation, surgery, that all could have been avoided. So, and the thing is, my insurance company still denied the payment of the genomic testing. So somewhere that needs to change on what insurance companies are doing. It has to be affordable for patients. And then finally, I just want to echo what both Keith and Miranda said, was connecting with other patients who have NTRK has been the most valuable thing for me. It makes me a stronger patient. I'm more informed when I go into the doctor's office. And it's been a great experience. And that's the reason why I started that Facebook group, because I didn't want to go through this alone.
And I know that all three of you, not only have you not had to go through it alone, but you have made sure that others didn't have to go through it alone, that you've been trailblazers, and you've helped other people who are earlier in their journey to make sure that they get the testing that they need and are asking the right kinds of questions. So thank you for what you've done around all of this. Really, really good and important work. So thank you for that. We're gonna open it up to a broader group discussion now, and think a little bit about what are the real challenges and support needs. So everybody who's participating, you're allowed to answer this poll. And so the question is, as a patient or the care partner of a patient with tract fusion cancer, what have been the most challenging issues that you have faced? And you can select all that apply to you. So if you could take a minute and poll, then we should be able to throw some results up on the screen. We want to make sure everybody has a chance to reply. Then we're going to ask our panelists to speak to this. And maybe, Sandra, you can rejoin the panel as well. We'd love to have your perspective on this. Okay, are we able to see the results yet? There we go. Okay, so this is interesting. 2/3 of people said no one told me about this, and another third said they had trouble getting genomic testing. And I'm curious from our panel what your reaction to this is. Surprising? Are you surprised it's so high or so low? What do you think?
I'm not surprised. And as Keith pointed out, unfortunately, some of these smaller communities aren't even aware of, again, are resistant to doing genomic testing, and that has to change. So if the doctors are resistant, then how are patients supposed to know about it? So I don't find it surprising.
Yeah, it's Sandra here. I don't find it surprising either. I mean, when you're talking about the amount of, not to toot something like MD Anderson's horn, and I understand that not everybody has the possibility or the availability to come to some, like a primary, a tertiary, teaching hospital, but less than 5% of patients with cancer in America are treated at, a Dana-Farber or MD Anderson or Memorial Sloan Kettering. So, you've got more than 90% of patients being treated at, smaller oncology places. Not saying that that's not what should be happening, but I think if you're receiving treatment somewhere a little more local, you just maybe need to be a bit more vocal about your needs or asking questions.
And I've known community oncologists working locally who are really on top of these kinds of things, who are aware of the trials and things like that. But I've known others who weren't. And so I think that always, no matter where you're being treated, it's always a good idea to be an advocate for your own care, it seems to me.
Yeah, I also think it's, just because you go to a Memorial Sloan Kettering or MD Anderson or Dana-Farber once doesn't mean you have to receive all of your treatment there. If it's a possibility, maybe see an expert in your type of cancer one time at your initial diagnosis, or go back once a year or twice a year.
Yeah. And I'm curious about this one about, I had trouble getting genomic testing covered by insurance, and Susan, you spoke to that being the issue. Miranda and Keith, did you have trouble getting it covered, or no? Miranda, I think you said that you were able to get it covered, right?
Yeah, well, we had a clinical trial, so the testing was actually covered by the trial.
Yes, of course.
But we did have trouble with our insurance company with the procedures that go along with the trial. So the medication was covered, but the in-hospital procedures were not. So our insurance was like, we aren't going to cover this. And that's when I went and sought out an expert in insurance, and he told me to read the explanation of benefits. And sure enough, it said all procedures with regard to clinical trials should be covered. So I called our insurance and told them that, and then it was covered. But we did have a little bit. What had happened is they were trying to bill for a drug that hadn't been on the market yet. So it was causing a little bit of an issue that was just human error, and it all worked out. But we did have some issues with insurance as well starting
So
out.
I'm really intrigued, Miranda, by something you said, and Keith, I want to get your take on the coverage piece as well. But first, Miranda, you said you sought out somebody who was an expert in insurance. Was this, and you don't have to answer this, and it's not something we rehearsed or anything, but I'm just curious, is this a specialist that you hired to help you understand your insurance, or was it a service that you found available through maybe a nonprofit or through some other source?
It actually was a lot of through the grapevine. We found an attorney that was an expert, and we consulted him, a friend of a friend. So it was just happenstance. I was looking for answers. I found an attorney who worked for Blue Cross Blue Shield, and who was able to help me navigate our insurance. So I was really fortunate that I could find an expert that would speak with me. And then we also found another, through my husband's employer, we found a person who was kind of an expert in insurance who helped us get the right insurance initially to get to MD Anderson. So we had to kind of seek those people out on our own, and we were fortunate to be able to find people that were able to help us in our journey. But it did take a little bit to get to where we needed to be.
So I think the takeaway for probably the second and the third issue both here is that if you're getting issues, pushback from the insurance company, see if you can find an expert, look through your network, and maybe you can connect to someone, or look through your HR department where you work to see if you can connect to someone, because these things, most of us don't understand insurance language, and the people who do can be very, very helpful. So Keith, your perspective on any of this?
I was lucky. I had no trouble whatsoever, no questions asked. It was always covered by my insurance from the beginning. I've always heard that the secret is in the medical coding, and I was lucky. I guess, MD Anderson knew what they were doing, but also my insurance was really pretty standard. It was, and Cadillac insurance, I must say, is probably Blue Cross Blue Shield, that sort of thing. But I didn't have any trouble.
Okay, thank you. We had one question that just came through that goes back a little bit, and this is actually from my friend Kathy Oliver, who works with the Brain Tumor Alliance, and just does amazing work with people with brain tumors, asking about the tolerability of TRK inhibitors around side effects and quality of life, and particularly around brain tumors. Have these inhibitors been able to cross the blood-brain barrier and actually penetrate into the central nervous system? So I know this is a little bit off topic, but it's a great question. And Sandra, I don't know if you have the answer to that. If not, we can maybe track it down and get back.
Yeah, I mean, in terms of tolerability, when you look at I'll preface it by the fact that I'm not a patient and I'm not taking the drug, so I might have a biased view. So Susan and Keith and I'm sure Miranda can speak more. But typically when you're talking about anti-cancer therapy in general, TRK inhibitors are extremely tolerable. Most patients, the most common side effects are dizziness because of the way that the drug works. So it works on something called NTRK, actually stands for neurotrophin receptor kinase. So it works along like these nerves that are responsible for things like proprioception, so your ability to identify your surroundings, but typically extremely well tolerated in terms of anti-cancer therapies. Some people put on some weight, there is a little bit of nausea, and a strange phenomena from some patients that have like this withdrawal side effect when they are coming up to their next dose of drug, typically about an hour or two before their next dose of drug. But otherwise, very well tolerated. Patients' labs are usually not affected, ALT, AST a little bit. In terms of crossing the blood-brain barrier, there haven't been any, as I understand, there haven't been any formal studies looking at CNS and taking like CNS samples to see if it's in there, but multiple patients have responded. So one of the first non-small cell lung cancer patients had a metastatic disease in their brain that had shrunk, and there have been several patients with glioblastomas treated that have had over 50% regression in their tumors. So while there's no formal, it's certainly more than anecdotal that this one drug crosses the blood-brain barrier, and then the other FDA-approved drug has proven CNS penetration.
Perfect, thank you. And in the interest of time, we're going to move on to the next polling question, because we promised we would finish by 12:15, and that gives us 7 minutes. So I'm going to ask that people take a minute to address this poll, and we'll have a conversation about this. And while you're doing that, I'll take the liberty of talking a little bit, and I'm curious, I'd be interested, Susan, in you contributing here. One of the previous issues that was flagged, about 20% of people said you had trouble finding connections to other track fusion patients. And I think, Susan, this is exactly why you started the Facebook group, to try to address that. And others now are involved in trying to set up some additional support networks. We want to make sure that everybody can find someone who can help walk them through this journey, and it's critically important. So comments or more that you would want to say on that, Susan, while people are filling out this poll?
Yeah, so, well, I started on the clinical trial, and I was, I think, the second person at my hospital to be on a track inhibitor, and I found it very scary and lonely, starting a drug that I knew nobody else on, and that was the real reason why I reached out on to find people. And the most common response when I found people were, "Thank you, I found somebody, I didn't know nobody else." So there definitely is a when it's a rare cancer, and then you're on a rare with a rare drug, right, to fix it, there's a need for people to connect with each other.
Yeah.
So I'll be interested to see what the poll is on what people find to be important. But for me, it was the connection with people. So as much as I may have helped others, they've helped me probably more.
Very, very good. And Keith, is there anything that I know you've talked to a number of other patients as well. Is there anything that you could add? If you could take yourself off mute and address this. I hope you're still, yeah, thank you.
Yeah, I agree with Susan. I've heard a lot of that too. And I'm not that savvy when it comes to Facebook and social media, but what little I've participated, I have really found it quite valuable. Some of the other things I think would be good too, educational website. I know there are sources that are becoming available online that are quite informative. From a variety of sources. There's, different cancer groups are starting to learn about this and starting to post some things. Then, of course, some of the different businesses that are associated with it are starting web informational programs as well.
Yeah, very, very good. Thank you. And now we'll look at I think we're about ready to have our results, but while we're getting our results posted, maybe Miranda, in just a couple of seconds, you could talk about the importance for a parent of a child who has cancer of having peer support.
Oh, absolutely. So I'm a member of a lot of groups I'm a member of a lot of different groups, pediatric cancer groups, momcology, some other groups for parents and caregivers, primarily parents. And I met several other moms of thyroid cancer kids at a time when I was feeling extremely lonely, who were going through the same thing that I was. I met, I mean, several, meaning like 5, but it was a lot when I was, you know, feeling like I was overwhelmed and just all alone. And one of the people I met actually ended up going to get testing after Hunter was the first in our group to test positive. They all were kind of having resistance and not getting the results they needed to. But one of the people ended up going to MD Anderson after Hunter tested positive, and her son also tested positive. So, so it was really a great resource, and it, you know, we all kind of figured out. I don't know if the other moms have done the same, but at least one was having the issues also because her son was NTRK positive. So it can be life-saving, actually.
Thank you. And I think your comments from all 3 of you are reflected in the results of these polling here. That really the only one of the 4 or 5 concepts here that received much less than 50% of support was in-person meetings. I wonder how much that's affected by COVID-19. Nobody wants in-person meetings. Or maybe everybody wants it, but is a little concerned about it. But regardless, I think a strong feeling of support, of needing more of a community, education, and really look at this: 3/4 of people say more opportunities for things like this webinar and clinician Q&As and opportunities to really get out the questions that you want to have answered. And then the importance of patient and care partner stories as well is still quite strong. To hear what other people have gone through is a way to help with that. I would love for us to have a robust conversation about this, but I'm mindful of the fact that we promised to end in 2 minutes. And I know how quickly 2 minutes can go by. So I just would say, Susan, Sandra, Miranda, Keith, thank you all for your input. And thanks everyone for joining. I'm going to let Marcia have the last word, but before I turn it over, I will remind you, please complete the survey. You'll receive that by email. Thank you everyone for participating. If you have any questions, you have our email address. Feel free to reach back out. Follow us on social media. There's just a lot of good things happening. There's some real energy growing here, and this conversation was just, I thought, fantastic. So thanks to all. Marcia, I'll give it to you to say the last word and close us up.
Thank you so much, Tim. We are so thrilled to have had today Sandra and Susan, Miranda, and Keith as wonderful speakers and panelists who have been teaching us so much. We all have our marching orders on filling out the survey and connecting with social media. And I especially want to thank Tim Turnham, Jemima Warwick, and David Tahari of Boz Advisors for all their expertise and all the help they've given us to put this webinar together. They're each of them a delight to work with. So thank you all, and thank you so much for supporting this webinar today.
Very good. Thank you, everyone. Have a good rest of your day. Take care. Bye.